We're at the IAS meeting here in Vancouver, BC. We're here with Jurgen Rockstroh from the University of Bonn, Germany. And one of the things, you were at a press conference this morning. Was it?
Yeah, this morning.
This morning, God, seems like a year ago. It's been a busy morning. But it is important for us to cover some certain things that are important to our audience, which is relative risk. And I think that was one of the things that came out to me, because you understand with hepatitis C, there is relative risks that are as far as transmission. And the most important thing is that we understand that you can be infected, you can be tested and treated and reinfected. So this is something we need to know, everybody needs to know relative risks. And I know that there's probably more definitive evidence somewhere, but just give us some sense of what the risks would be.
Yeah, so obviously the highest risk for getting infected with hepatitis C comes from sharing of needles. Contaminated IV.
So don't share needles.
Exactly.
Use clean needles.
Exactly, and in countries where there are easily clean needles available, that also has a tremendous impact. You can see how transmission really goes down. In countries where IV drug use is completely criminalized, and you will not get access to clean needles, infection rates go up. So there's a clear an impact of reduction, harm reduction, and clean needles. Now, in the context of what we've now seen in the HIV infected MSM patient population is an outbreak of acute hepatitis C. It started in 2002. And obviously the question was, well, how did that suddenly happen? Because not so much has really changed. When we then looked phylogenetically, that's a way of sort of determining where these viruses coming from. They were very closely related. So it really suggests that some people with hepatitis C got into that scene, and then there was fast transmission in big cities in which many MSM live. Now, that raised the question, well, how did they get infected? Because at that time, at least, there was not so much intravenous drug use. And in all kind of different analysis trying to assess what was associated with the highest risk, it was really all around sexual practices which were associated with an increased risk of a blood-blood contact. So that was unprotected anal intercourse and fisting were pretty much the ones which stuck out there with the highest
sex where there's blood involved.
Exactly, and that's important because you also should know that in the context of hepatitis C counseling, in the setting of heterosexual discordant couples, there's not even a necessity or not a 100% recommendation to use condoms because the overall transmission is low. There is, though, the recommendation not to have sex during menstrual bleeding. So there is already sort of, at least in literature, you will find that there is very little probability of sexual risk. So this whole term sexual transmission becomes a little bit complicated because everyone understands something different around it. So it's not necessarily sex per se, but it's really the sexual practice which involves something which has a higher risk for a blood-blood contact. And I think what has, though, changed the epidemic as well is that the pattern of drug use has changed. So whereas in the early questionnaires and examinations, it was really all about cocaine use, and there was also evidence that intranasal cocaine use through common same intranasal devices can also be a source of infection. But now it has all moved to crystal meth and other amphetamines, and many of them are given intravenously, particularly when people meet to have sex and then slam together. And that sharing of needles, obviously, just as in IV drug use, is also associated with a high risk. But that's a little bit difficult as a message because people who occasionally take drugs in the context of having sex with someone do not identify themselves as IV drug users and are not sort of pertinent to the messages which come with harm reduction around IV drug use in the context of regularly shooting up heroin or something like that. So that has been, I think, one big issue in how we communicate with the affected populations of, getting the message out that there is a risk of reinfection, first of all, and secondly, that, that needle sharing per se is, a risk factor and also in that context, and that needs to be educated to everyone.
So there's this issue around receptive anal intercourse in such a way. And maybe, is there any fecal oral issues there?
Yeah, so, unfortunately, we do not have the wealth of data where for every different thing. But hepatitis C per se is much less transmittable than HIV. So We do not believe that there is an oral transmission. And you could also say, well, what if I have receptive anal intercourse without bleeding? Then I think the risk is actually quite low. But you shouldn't forget that many of these infections are noted after sex parties where people have intercourse with many different people. And clearly when the third person has sex with you and there is a corresponding, has been a corresponding prior irritation, the mucosa, which is already sensitized and may bleed on certain parts, that I think is where the risk really starts. So it's because in the multivariate analysis, there was also, having multiple partners in one event was associated with an increased risk. Recent anal surgery, in the case of condyloma or things like that, was also associated, and these would be indices for a higher risk of bleeding altogether.
It'd be a cofactor in the way the entry endpoint. Is there anything else you want to bring up quickly? Because I realized the meeting was just about this, but this was a point that struck me as being important to get out to our audience.
Well, I think I'm grateful for re-emphasizing that we have to, talk about this, because the reinfection rate in the European database of MSM with HIV who got acute hepatitis C and got reinfected is actually 25% in 2 years. So obviously with the high cost of the DA, and if that ever gets established as a therapy, you would at least sort of wonder how often is that going to be paid by an insurance company, and shouldn't there be real efforts to try to come to some kind of harm reduction, which would mean that we have to tackle people and say, listen guys, at least use clean needles and so forth, and that's something which has to first be introduced into that group.
There has to be some certain personal responsibility, and I know that that's hard to do, but we have to do it. And we maybe should have support groups, buddy programs, meetings.
I think we need better data, because when you counsel a patient, he says, I did everything. I'm so afraid of getting it again, and am I really safe in what I'm doing? And I think that's so. We're also asking, obviously,
they want good and honest and reportable and evidentiary advice.
Absolutely.
Yeah. Well, I appreciate you taking the time with me.
All right.
It's been
Thank
very,
you.
very appreciated, and I'm hopeful that we can get more on this. Like you said, this is out still.
It's work in progress.
Work in progress, as science is.
And that's what science is all about.
We can always come back and say, no, we added this now, because this is also something we look at.
All right.
Jurgen, thank you so much for being here.
Pleasure.
Yes.